pioneer in bringing about this family adoption activity as a part of the learning from the past 25 years, that what you have heard. So in this regard, I am honored to introduce him. At present, Dr. Subodh S Gupta is working as professor in the social pediatrics, also heading the Department of Community Medicine. He is associated actively with this community-based medical education for the past 25 years, stressing on the innovation and motivation of the younger faculty and the health professionals alike. As a coordinator of the medical education unit at his institute, he has developed the blended learning courses utilized by innumerable faculty members via offline as well as online courses. He had been a focal person for the Child Development Program of the WHO from 2010 and 2012. He has contributed for the ongoing RBSK, Rashtriya Bal Swasthya Karyakram of our government, along with Indian Newborn Action Plan, and is one of the important member of the National Steering Committee. And the second part of my activity is a pleasure. It's a pleasure to be a part and be a witness to hear from the experienced resource person to shed more light upon this, how this family adoption program goes a long way and how it has been helping the students in their institute in acquiring these skills. Now over to Dr. Subodh Gupta to share his experience.
Yeah, good afternoon, everyone. And it's my pleasure to be here in front of you. And thank you so much, Dr. Prasanna, for a kind introduction. I'd also like to express my thanks to Dr. Vinuta Shankar for inviting me and coordinating with me this session, and Dr. Subhashish Das. Yeah, let me just share my screen, and then I'll start. Okay, I hope this is visible to you.
Yes, sir.
Yeah. So, basically, I would like to say that I bring greetings from Sewagram to all of you. And talking about Sewagram, we have the privilege of standing on the shoulders of giants. So this institute at Sewagram, Mahatma Gandhi Institute of Medical Sciences, actually, this was upgraded in 1969 from a small hospital. But that hospital was started by none other than Gandhi himself. So this is one hospital in the country which was inaugurated by Gandhi, and this was done immediately after the death of Kasturba. That's why it was named as Kasturba Hospital. And I would like to name our founder director, Dr. Sushila Nair, who started this the small hospital, but also was the person who came with the idea of upgrading this to a medical college in 1969, the Gandhi centenary year. And when this college was upgraded to medical college, Dr. Sushila Nair's dream was that we produce doctors for rural India. And for that purpose, she initiated various innovations in this institute. And one of those innovations was the family adoption program. We call it a social service camp and village adoption scheme because during that time we adopted villages, and even now we adopt villages. Wardha is a small town, and for us it is relevant that we do village adoption. And this is now today when one of her students, Dr. Aruna Vanikar, is the president of UG board in NMC, she decided to disseminate this model in a way we can say, or she made it mandatory for all institutes to start this family adoption program. So basically the credit for this goes to Dr. Sushila Nair, who visualized this. And our institute is running this program, the social service camp and village adoption scheme, since its inception in 1969. So I think this was already we had 52 batches who have passed out, and they have experienced the social service camp and village adoption scheme, or currently they are experiencing this. Of course, during COVID, there had been challenges, and we could not continue the village visits during COVID period for almost 1 year, I should say. But again, we have been able to restore this. Yeah, I'm in this institute since 1997, and I'll be completing 25 years in this institute. So I have witnessed this program for the last 25 years, and in various capacities, I've tried to bring in some changes, some innovations in the program. So today, it's a privilege for me to share my experiences with you. Well, I'm going to talk about this. Basically, I would divide my talk in 4 sections. In the first part, we will try to understand why such program is required. In the second part, I will try to brief you how we do it at Sewagram. And then we'll listen to some of the feedbacks from our undergraduate students. And then finally, maybe based on our experiences, a few lessons that I will be able to share with you, what we should do and what we should not do, maybe on that part. So when Dr. Vinuta contacted me and she asked me what should be the topic, so basically it came to my mind that we talk about family adoption program and how it would be important for making of socially responsive health professionals. At Sewagram, we have experience of doing this program for medical students, but I understand that this would be relevant for all health professionals, and your university being there are several courses, so you may explore the possibility of doing with other professionals as well. But the first thing I would basically like you to recall your younger age when you joined medicine or any allied branches, nursing or dental, etc. And what were your ideals when you joined the profession? And then I would also urge you to think about your self-perception of your competence when you passed out. I'll just give you a minute time to think over this. When it comes to self-perception of your competence, you may also think how the ideals, the purpose that you thought when you joined health profession, did it change when you passed out? Will anybody like to share something from the group? Okay, we do understand that, and I feel that a large proportion of our students, when they join the profession, they have very high ideals. of serving the community. But when we pass out, we have a perception of incompetence, that what we wanted to do, probably we are incapable of doing that. And in the meantime, there are other processes also that probably changes the perspective with which we joined the medical profession. But so here we come to a question. What kind of health professionals do we need in the country? And if we have to, I have to answer this question, I would like to put it in one phrase that would be socially responsive. Socially responsive would mean that we are able to understand people's need. We are able to, we are sensitive to people's need or society's need, and we are capable of responding to those needs. Is it the current situation? Are we able to produce health professionals who are socially responsive? And if it is not happening, what could be the solutions? I think I would like you to respond if it is possible. So what comes to your mind, how we can improve the situation if you agree with me that the current, like the way our students are being trained, and when they pass out, they are not socially responsible, or largely we are not socially responsive in this field. So what could be the solutions? Basically, one problem that happens with medical education, that our science, the medical science or the teaching is dominated by science and technology. I had been thinking about this, and especially in the last month, I had been thinking about it, and it did also came to my mind that probably from very beginning, we are made to believe that medicine is all about science. And that is the reason that the subjects on which our students are tested prior to joining any health profession, those are physics, chemistry, and biology. So we keep those social sciences away, but medicine is also about sociology. Probably if we want a socially responsive doctor or health professional, we'll have to start thinking from where it starts. The initial impression that is made on the minds of people about medicine, we need to begin there. But when they join the medical profession or any health professional education, at that time also, it is important that they are allowed to understand people in their social context in more holistic way. When they are closer to the people, they are able to understand their needs, their problems, and probably they will be more capable to deal with those problems when they pass out from a medical college or any health professional institute. Then another problem is that the training is conducted only within the four walls of a tertiary care center. This seems very unfair that those students who are trained within a tertiary care hospital only, they are expected when they pass out to go and serve at primary and secondary healthcare settings. So gradually it is important that we need to change our system, change the training, so that training is conducted in full spectrum of healthcare settings, and it is integrated with primary and secondary healthcare also. And for this purpose, academic institutes would require to develop partnership at different levels. So the partnership would be required with the community and also with the public healthcare delivery system. But it's not only healthcare delivery system, because lots of other sectors also become important when it comes to health services, or at least determinants of health that we think about. So other sectors also. So here I would like to go back to a few definitions and a few terms that are usually used. So one of those terms is community-oriented medical education. And community, basically, it is defined as medical education that takes into considerations all aspects of its operation and the basically, it is about the priority health problems of the country in which it is, or geographical region where it is being conveyed. And its aim is to produce community-oriented doctors who are able and willing to serve their community and deal effectively with health problems at primary, secondary, and tertiary levels. And a related term is community-based medical education, and this is used for medical education, where activities that use the community extensively as a learning environment, where students, teachers, community members, and representatives of the sectors are actively engaged throughout the educational experience of providing medical education. And this is relevant to the community needs. This definition was given in a TRS of WHO, World Health Organization, in 1987. And I would like to see both of these together. So sometimes a difference is being made between community-oriented medical education and community-based medical education. I would like to say that our medical education or health professionals education should be community-oriented, and that would be possible only if at least some proportion of it is also community-based. And let me move to another a model. So I'm presenting to you a model given by Paul Wardley from Australia. And in his landmark article, Paul Wardley talks about 4 relationships or 4 R's he tells. And this is talking in context of community-based medical education. So basically, he says that 4 axes become important. One axis is a clinical axis, where it is about curative care, or clinical care, I should say, not curative care, clinical care and doctor-patient relationship. Today only, I'd been to a village where we assist our students in a village, in the village that they have adopted, and I visited their families. So there were so many cases that our students have encountered during this family adoption program, and each case becomes a trigger for them to seek further knowledge. And this is not only about management of the patients, but it could also be related to determinants of various diseases, social determinants of health. It is about what patients accept and the doctor-patient relationship that is built from very beginning. Another axis Paul Wardley talks about is a social axis, and he puts government and community. So he talks about that this gives our students opportunity to understand the needs of the community. It could be an individual need or need of the population, and what are the challenges. It could be demographic, geographic, cultural challenges. It is also about government policies, law, funding, that kind of environment, and how a kind of tension between the community needs and government programs, or what we are offering to the community. A third axis, according to Paul Wardley, is the axis of health service and university research, where students may understand the evidence, research evidence that is available and how it could be utilized for clinical decision making. And here I would like to say that this is not only research evidence related to treatment of patients, but it could also be evidence related to our policies and programs and a kind of innovations in the program. And the fourth axis is about the personal principles and professional expectations. And here the ethics, moral values, etc. comes into play. So community-based medical education may provide a very rich environment for development of healthcare professionals, and it can force them to think about the need of the community and how, as a professional, he or she would try to satisfy those needs in the given environment, in the framework which is given. So in short, I would like to say that for rationale of a community-based medical education, first, it is a social responsibility of each medical institute. It also relates theoretical knowledge to practical training, and it helps keep education up to date by confronting students with the reality, where an actual patient becomes a trigger for the student, and the student is able to understand that patient in its total environment that he or she will not be able to do in the hospital setting. It also enhances motivation. It breaks down the barriers between a trained professional and a lay public. Basically, these are the reasons. I'm not going to explain all these points, but I think that rationale is very obvious. And especially, I understand that I'm talking to a group of converted. I would think that this much is enough. So now let me go to this part, how we are doing at Sewagram. First thing I would like to emphasize that at Sewagram, we believe in a long-term relationship with the community. And we have a field practice area about 100 villages. And in these villages, we continuously engage with the villages, the Gram Panchayat, village health, nutrition, sanitation committees, and also various community-based organizations like self-help groups of women. We have adolescent girls group, we call them Kishori Panchayat. This is the way we engage with the community. And we also have several community-based programs. We keep on adding them or upgrading them. So in about 15 years back, we had a community ownership program. This was done with a partnership with USAID, basically. And what we learned through that program and the community mobilization that was achieved during that period continues even now. We have family life education for adolescents. We have a nurturing care initiative, which we started in this area. And actually, this is being scaled up for a wider geographic area now. In recent times, we have started an intergenerational programming. So how we can work with the elderly. So various community-based programs we do with this population. This becomes our field practice area. So students will also be able to understand from this field practice area what can be done in the community. And then for the students, it's not only the village adoption or family adoption program, but basically there are several stages of it. So we start with an orientation camp of 2 weeks immediately after our students take admission in the institute. And thereafter, we have a village adoption scheme, which starts 3 months after admission. I'll tell you details about that. During the 6th semester, we have an reorientation of medical education camp. And during this camp, our approach is, our objective is that students get exposed to the healthcare delivery system in India, and they get oriented to the skills that they require, they would require if they are working for the healthcare delivery, the public healthcare delivery system. And then in internship training, a part of training, and this is part of NMC, so therefore it will be it would be done in every college, but we have our rural health training centers and urban health training center, and a part of training is also done there, where the students get another opportunity to go back to the villages and the healthcare facilities. So basically, our village adoption scheme starts with a social service camp. We call it social service camp. And for this, for each batch of students, medical students, we adopt a new village. This approximately about 1,500 to 2,000 population is such that each of our students will be allocated 3 to 5 families. And this is not, it does not end with the camp of 2 weeks. Basically, our students will keep on visiting this village for another 3.5 years till they appear in the examination for community medicine. This provides our students opportunity to learn about rural life, environmental sanitation, all the realities in the rural areas. And as we all can understand, many of our students, when they take admission in the college, they may not have experienced rural life or would have seen this from close quarters. So it is an encounter to them with the reality of rural life. The students look after the health needs of their allotted families by monthly follow-up visits. I already told that. And initially, when they join, because the camp is conducted in the first year, at that time, they may not have enough capacity or knowledge and skills to counsel the family, but gradually we build their capacity so that they are able to counsel the families on various topics. Okay. During the camp, the students build rapport with the families, and they facilitate complete checkup of all family members, and they also facilitate management of any ailment, common ailment that the family is suffering. We also create a mobility profile and nutritional profile of the villagers. I would like to emphasize here that it has to be a give and take kind of thing. So while our students get an opportunity to learn from the villagers, and I would like to keep that as the first objective of this camp, it's important that villagers also get benefited from this process. And for that purpose, during the period of the camp, complete checkup of all family members is done. And we run a general OPD in the village where these patients, whoever is detected to have a condition, an ailment is brought, is managed. We also have a specialist clinic. And for the period of the camp and approximately 10 days after the camp, if these any of these members require admission in the hospital, so their management will be available through our hospital free of cost. Even if they need some operative procedure, it will be free for them. And our students also get opportunity to observe community mobilization, and they are able to interact with community members and healthcare providers. The camp is supported by various sessions on not only on health, but social issues, communication and leadership skills, demonstrations of qualitative methods. And we gradually build the capacity of our students for providing health education messages to counsel them as they come to them. Over the last few years, early clinical exposure is being emphasized by MCI and now NMC. And I would like to say that this setting of family adoption scheme is also a very good setting for early clinical exposure for our students. And already I've talked to you about monthly follow-up visits. During monthly follow-up visits, our students work on specific objectives for each family. When they are during the camp, at that time, we encourage them and we work with them to develop a specific objective for each family. So this could be a very simple objective that they would like bring in some behavior change in the family. Like if there is some a person who is addicted to tobacco, they would try to reduce that addiction, or it would be to improve dietary practices, or it could be related to improving compliance to some treatment, and all of our strengths make objectives for the family. So during each of those follow-up visits, they would work on those specific objectives they have prepared for their family. Every visit is also has a theme, and on the right side in the photograph, you can see this is from an image taken from journal of one of our students, that for every visit we'll have a theme and they would be informed about this theme. So during their family visits, they would explore with the family members their practices on that theme. We also provide some group work to the students. So in groups, they might visit ASHA and Anganwadi worker or ANM to understand what are the services that they provide. Or they may meet the Gram Panchayat members or members of Village Health Nutrition Sanitation Committee to understand what they are doing for health. Or they will take a transect walk of the village to understand the vector breeding places in the village, or to understand other aspects. During third year, they also engage in a short research project in their adopted village. And this we do under the banner of problem solving for better health. Probably you would have been part of this problem solving for better health, which was started by an organization in Kerala, Health Action by People. So we conduct a 2-day workshop on research methodology. We usually do not call it research methodology to them. It's a kind of problem solving where students identify a problem, frame a good question, and develop a protocol, and then they implement that and try to find out answer to this. Some of these works that our students have done have also been published later. These slides show or demonstrate the qualitative methods that our students are exposed to during the village adoption scheme, and some of the photographs for health promotion and sanitation drive that they are engaged in. Okay, so now I have some videos from our program, and I'd like to show you those videos. Just wait. Okay. I hope I am audible and there are no problems.
Yes, sir.
Fine. So I'm switching this.
Hello everyone, I am Suryadev Devi of 2007.
So it's audible. The video is audible.
Yes, sir.
And regarding the village adoption scheme, I would like to say that from my experience, it was an eye-opening program. We were introduced to our adopted village and families during the social service camp. The camp was held during the first year of our MBBS, and as budding medical students, we were unaware of the realities of our patients' lives at their homes in their natural setting. I come from an urban area in the state of Karnataka, so to me, by walking through the streets of the village and sitting in the homes of my family members, I was able to develop a new perspective and began to see my adopted members in a new light. Additionally, since I'm hailing from a different state, I faced certain challenges in communication, which I was able to overcome by spending more time over the SSC and via the future monthly visits we had. I believe the family taught me much more about the language, culture, and tradition of the people than I could ever learn on my own. And during and following the camp, we got to know more about the health problems of our villagers. And we were also encouraged to refer our villagers to visiting doctors and follow up their treatment. As a second-year student, this gave me practical knowledge and motivation to further study these topics. Also, seeing firsthand the environmental, social, and other aspects of health made me realize how important a family or community-oriented approach to health is. Further, we were also exposed to research, and we had to write a village report during the SSC. So this was very useful in the future when I took part in short-term research projects. All in all, I would like to say that the village adoption scheme taught me something which I could never learn within the walls of a classroom or hospital, but which will be quintessential when I'm managing a patient within those very walls.
Hello everyone, I am Jasnoor Kaur from 2018 batch of NGIMS, and today I would like to talk about the village adoption scheme practiced here. The village we adopted was Manva, and we were first introduced to them back in 2018. We had a social service camp for 15 days, and that is how we gradually got to know them. And since then, we've been having monthly visits every month. And even though COVID did cut short our time, we still formed great bonds with the family members and learned a lot more about community medicine. Seeing problems like poverty and poor sanitation, poor household, ill ventilation, when you see these problems firsthand, you actually see how they affect health and how it is actually very prevalent. As members of a better society, we would think that these things are not prevalent. Poor hygiene or waterlogging is not present, but it is very much there, and it is us who need to tackle this problem, and we need to do it when we go to the community. We cannot do it sitting in our classrooms. So that is what I learned. And my feedback is that when you try to absorb things from the community teaches you a lot. You learn about the risk factors which are written in every textbook. These are some things you could never learn in a textbook. And also a takeaway or a thing that has stuck with me was that once I was having a snack my family members offered me, and then it told me that, Doctor, let's go wash our hands first before we eat. And that had such a positive impact on me that I taught these children how to wash their hands, and a few months later, they are telling me that, Doctor, let's go wash our hands first. So that is one thing that really touched me and filled me up with positivity, that whatever we are doing, we are going in the right direction. Coming from a different culture, I am not Maharashtrian. I learned so much about their cultural practices, about their language, and in general, I learned the things about community medicine that I would not have learned otherwise.
Hi, this is Dr. Vidit Panchal from the batch of 2013, and our batch adopted the village Selukate during our first year. And there have been some great memories and learnings that are associated with that camp and the visits that followed that have stayed with me over the years, and some of which that I tried to implement in my practice. Just to mention, one of them is the contextual history. So during our village visits into our respective adopted families, we were supposed to take cases from that family about which we used to identify problems at personal, family, and community level, And then we were supposed to formulate solutions for that problem at personal, family, and community level. And it really broadened my perspective regarding the origin of a disease, that like how a disease originates, why the person fell sick in the first place, what are his ideas and perceptions about his disease, what are his expectations from the medical consultation, and how I can formulate a solution that will be acceptable to his condition. And even today, when I see a patient, I try to note down the contextual history because I want to know where the person is coming from and where he will go after my treatment. That has really helped me plan a better and a more holistic treatment than earlier. And this is something that I found really. And among the many lessons that were there in that whole process of camp and the village visits was a lesson that the villagers already know what they want, and they are already much smarter than what I think. Because as doctors, we always tend to think that just because we read better, we live in better conditions, we are exposed to better things, so we might be knowing better than them, which is not the case. The villagers have a lot of latent wisdom with them, which they have amassed over thousands of years. And there is an equal opportunity for doctors to learn from them as much as they have to learn from us. And therefore, whenever we approach a person, it should be taken as a learning opportunity, not a teaching opportunity. And that is something that has stayed with me really strongly.
So,
these were some of the feedbacks from our student that we especially recorded for this kind of dissemination recently. And so we were also talking with other students, and what we realized that it affects them in many different ways. And some time back, I was showing you about the 4R from Paul Verdery, and we do get in our students' feedback that probably all those 4 axes are important, and village family adoption scheme or village adoption scheme is helping them learn all those aspects. Like one of our students here says that any work in health that does not benefit the rural masses needs reforms and reflections. I figured that as a person, there are many ways to be useful, and there are certain qualities of mine that I could discover during the whole process of adoption scheme. Okay, so similarly, there is a reflection here below, which says, got first-hand experience of expectations of people from us and how we can leverage that expectations with our know-how. So apart from this, how the villagers treat our strengths and how do they accept this program, that is also something which is very important, especially when we are working through Sewagram, and we have been doing this camp for 50 years. The villagers in the neighboring neighborhood of Sewagram, they are keen to welcome our strengths, and they usually come with a proposal to have this camp. And you would, when you witness a relationship of our students with the villagers, with the families which have been allocated to them, you would realize the depth of that relationship. So in the words of one of the villagers, he says, I had always wanted one of my child to be a doctor, and today I feel as if my own son is becoming a doctor. I thank the Almighty for the same. As I was telling you in the beginning, today I visited 7 of my students for assessing them in their families, and I was overwhelmed by the relationship I saw between the family members and the students. Okay, now coming to the last part of the talk, and I would like to emphasize some of these things. So I start with this quotation from Robert Fulghum, and he says, don't worry that they never listen to you. Worry that they are always watching you. And this is very important. And from this, I would like to derive a few lessons for us. So it excites me when there is an environment where family adoption program will probably roll out in many medical colleges, probably all medical colleges, I'm not sure. But we definitely need to be careful. Is it only about the family adoption program that we take our students to the village? Or we have a purpose attached to it? I understand that many have, and of course, NMC has a purpose attached, but each and every teacher, each and every professional from the medical college who is involved in this program should be part of the shared vision that what we want to achieve through this. Otherwise, what happens that we mistake means for end, and just seeing that these family adoption, these visits or camps run smooth could be our ultimate aim. This is not going to serve. We should have a clear vision. Each and every institute should have a clear vision regarding what needs to be achieved through this. The second part is we need to see it in the larger educational environment, what we are doing. There are lots of components in that educational environment. Some of those components which may not find lots of attention, I would like to especially point out towards the softer part, the relationships. The relationships between teachers and students, how we aspire them, that is going to be very important. And then we need to be role models to them. We are their role models in whatever good or bad role modeling we do for them. We are always, teachers are always role models for them. So until we provide a good role modeling, and especially when it comes to social responsiveness, this will not work. For me, everything is about trusting relationships. So we need to develop a trusting relationship. We need to trust our students even for their responsiveness. And if we trust them, then you would see it happen. Another thing, and I would, in my next slide, I will emphasize more on this, is should we make it kind of just mandatory and all activities decided by the teachers, or should we make it a student-led process, or a balance of it at least? At least we need to have some component of it which is student-led. I know that a large part of it which will be led by the curriculum, the teacher, that is important, but some part of it must be a student-led process. And the partnerships with the already I discussed about the partnerships in the previous slide, including community and other stakeholders. I was last week I was talking at Vijayawada regarding on the same topic, and after the talk, some of the teachers from community medicine came to me, and they told me about the challenges they are facing when they move forward for family adoption program. And when I was talking to them, what struck me is this, that we need to find a win-win. So the challenges that they explained to me was related to the institution, what the institution is expecting them from the family adoption program, and what it is ready to give for the program, and then what the community is wanting from it. Also, the challenge would be regarding the students. Although I've not put a third circle, but there should be a third circle for the student and what they want. And then we need to find out where is the win-win for all three stakeholders. We may discuss this in detail, but the success lies in that win-win situation. Okay, I was talking about student-led initiatives, and yeah, I would like to brief you what we have experienced in the last few years at Sewagram. So there had been a few students who were driven by a cause joined our institute, and one teacher also. And a student-led process start. They named themselves White Coat Army, and these students would go to the hospital wards. They would collect people. They had some objectives like they acted against addictions, alcoholism and tobacco addiction, and they started counseling them, taking health education for them. It was not just restricted to those activities. They started several other activities. They would also sit together to discuss various issues related to the determinants of health, how the health inequity, the best models which are available in the world for health delivery. And this was totally student-led. This was not a class by a lecture class by the teachers. It was just catalyzed by one or two teachers, a very subtle catalytic process. And we saw lots of changes with that. Today, also, some of my students came to me, and it is a Students Initiative. They said that they want to visit their adopted village during the breastfeeding week, in the first week of August, and they want to spread awareness regarding breastfeeding in their village. So this part we need to pay attention to and think how some of the components in this may have some flexibility, and we allow student-led processes. And I would like to mention this also. We are located very close to an organization known as Search in Gadchiroli. You probably know Dr. Abhay Bang. Many of you would know Dr. Abhay Bang. And it's an organization, huge organization. And in the last few years, they have started a youth flourishing framework. And they identify rural youth who have identified a purpose in their life. They want to return back to the, or at least they have intention to return back to the villages, and how to mentor them. And some of these students joined us. And I would like to say that this was very helpful to us. So what we are doing just in the four walls of a medical college may not be everything. And probably such organizations in our neighborhood could be very helpful, who can have an impression on the young minds prior to they join in the medical college, or even when they are in a medical college, but they may have influence on these younger minds. I think this is last but one slide, and just few underlying principles. When we are planning a family adoption program, there should be planned educational goals and objectives. It should be introduced very early in the educational experience and should continue throughout the educational program. And it should be a standard, integral, and continuing part of the educational process. Another important thing is that students' work should be a real work. So it's not mock exercises. We need to make it real exercises. And this would also be very important. Okay, so I end here with some of the photographs I received just last week from two of our students who are alumni, basically, I should call them now, who are serving in the flood-affected areas in Assam. So I stop here. I understand I have taken a slightly longer time, and it would be my pleasure to respond to queries that you have related to family adoption program. Thank you very much.
Thank you so much, sir. It has been such a wonderful session, and I would rather say that attending so many CISP workshops and sessions on community-based education, sort of one practical narration and experience of yours has really superseded any of these that we attended. I'm so thankful and indebted to you for at least making us understand that it works and it is doable. Like when we see things happening and when constrained resource areas too. So it would inspire us, be it administrators or leaders or faculty at respective departments at every level. In fact, you even started off from the preclinical level of early clinical exposure. You showed how things work. We wish we had a really long session of workshop and brainstorming sessions as to how to do it. Like there were very fascinating facts as to you showed us how to introduce qualitative studies there and those Venn diagrams that you showed, and how you took us incrementally from phase 1 to phase 2 to phase 3. Thank you so much, sir. I would like to open this for discussion. If you have any questions, either you can raise your hands and ask, or you can leave it in the chat box. So do you have 5 minutes time, sir,
Yeah,
for the
definitely.
interaction?
Definitely. I am available.
Yes.
So
Good afternoon, sir. Dr. Prasanna here, from the Department of Community Medicine. It was indeed a pleasure to listen to your experience in practicing this program for pretty long years. And to mention, we also had a very similar program ongoing for the past 3 years. In 2018, before that also, we were having this 3 days of early community exposure for the first MBBS batch only, which was since 2012-13. So later on, gradually, we realized that just one contact won't be sufficient, may not be sufficient for the students to understand the needs and how to approach them with the probable solutions. So we converted this into what is called as the student family program in 2018-19, and coincidentally, it happened to be the first batch of CBME before the NMC has requested our including this family adoption program. There it was planned for 3 contacts in first contact for second year, second in the third year, and culminating in during the internship. And these contacts was for a duration of 6 working days, wherein we used to take a batch of 12 students divided into 3 groups of 4 members each. The difficulty what we encountered was, since ours is a deemed university, the students were from different parts of the country. Language was the main constraint. So in order to accommodate this, what we did was at least one student among the group had to be having a working language so that he will be able to communicate. So this was going on, and because it's COVID, we could not completely implement it in the first year. But for the second year, we have been doing this. But in this journey, suddenly the NMC asked us to bring about this family adoption program, which again, about which I've got a reservation. The reservation and limitation happens to be that when a student gets in contact with the family only once a month, then there will be a long gap of 1 month between the next contact. But this, the NMC has advised to go on the entire 5.5 years. Fair enough, the duration is okay. But this limited contact of 1 day, that is matter of 2 hours, to the maximum of 2 hours of contact of the students with the family, with a long gap of 30 days, 25 to 30 days, having their core subject to prepare also. How much amount of their experience in the previous contact will they be able to carry it forward for the next month? And how much amount of this attachment can they develop with the families as compared to what we had planned earlier? It was very similar on the lines, whatever you have experienced as your experiencer. Those 5 days of contact with a faculty member and 2 postgraduates who will be interacting and coordinating and providing possible solutions and performing. The gap between the first and second contact, they were given the task of telephonic communication with the family once a month. Every student of the group had to be in communication with the family members to ask, to seek, and to provide, and this had to be recorded. And 2 groups of the students were assigned a family, a PG, who would be the nodal officer in the hospital for all those people from those families when they approach to our hospital. This was the one plan. So my always reservation is when we identified that 5 to 6 days of continuous contact interspersed with this telephonic communication for 3 years. That would have been better as compared to 1 day of contact with 1 month of gap, carrying it forward for 5 years. how would you think this will be helpful as compared to your model and what we had planned earlier?
Yeah, I got it. So basically at Sewagram, what we are doing is first there is 2 weeks of camp in the village. So during the camp, every day they would meet the family members, and during this camp, the 2 weeks duration, they develop adequate rapport with the family. And with this rapport, which is developed initially, it continues for, and thereafter we have once in a month activity. And in our experience, that once in a month activity helps because this during this period, the strengths that those families may experience different kind of health problems or health events, and our students will get an opportunity to learn from those their health seeking practices, etc., their challenges. We have those theme based visits, and that also helps them learn, and the students grow with that. So starting from the first year till final year. See, the emphasis is not on not only on what the villagers receive. Emphasis is also on how our students benefit. They learn, and for their learning, it becomes very important that they start very early when they join medical college. So this 1 month duration is not a huge problem. In my our experience, it works if they keep on visiting at an interval of 1 month. And there are months when it is not possible, especially summer vacation or when they have exam. So it might become 2 months or occasionally 3 months, a few visits. That works. That is not a huge problem. But there should be some initial period where when they are able to build rapport. Usually we used to have that for 2 weeks, but during COVID times for 2020 batch, we had a camp of just 10 days duration, where students would, if we minus the first day and the last day of the camp, they would have interacted with the family at least on 8 of those days. So that initial interaction, I would say, would be, to our understanding, it would be very important. If it is otherwise, we'll have to experiment and find out if it works without the initial period where they interact with them daily.
Thank you very much, sir.
Yeah, there is one question Dr. Sarla Devi wants to ask, sir. How can you integrate anatomy in this community-based education? She wants some tips on that.
Then I think you are the best person, madam, to think how you can integrate anatomy. And I would like to ask you how you are integrating for early clinical exposure. So that applied thing that you bring when you are doing for early clinical exposure, you bring clinicians and they are able to share on some of those topics. So there could be some deformities, spinal deformities, etc., that the cases you will find, especially although we did not work, but we earlier we had a proposal from anatomy, something related to genetic conditions, and they wanted to visit the community and identify them or work with them. But I think if we work together, in our institute, it is not so much integrated with the clinical departments. I would like to bring this integration more. But if we sit together and try to brainstorm ideas, there would be lots of things that would come there. Yes, I have a proposal from a faculty member in biochemistry who has a project for her medical education course, and she's going to visit us for finding out opportunities to teach biochemistry during the community, these visits. So probably I'll be able to share that after some time. But if we
yes, sir. Actually,
which would be possible.
Actually, yeah, things like anthropometric data and nutrition, cognition, small things that we try to do, integrate in the curriculum. Somehow it integrates with one of the outcome that we are talking about. And students have been doing pretty well. So anatomy, as you told, genetics was something that even I was thinking, like certain areas, like genetically, like predominantly certain diseases that they could look at. And nowadays molecular biology is a big thing. So to start off right from the beginning and see how in the community level, how they can work on it. So I think it's all about brainstorming and then talking among each other and trying in a small way rather than wait until you get a perfect template. So and then